welcome you all in Pedia Academy by Dr. Pankaj. We are here today to start an amazing series on revision, fast track revision for NEET SS Pediatric. This series will be amazing. This series will cover the important, most important topics and including previous years asked topics also. This will be exam oriented and you will get most of it in a short duration of time. But just remember, this is not a replacement of regular reading or regular long videos. Basically, it is just a summary or crux 11th hour of exam. So just enjoy this. We are starting our first series or first video on rheumatology, rheumatic disorders. So without wasting time, uh, let's start it. Okay, so in rheumatology, we'll start with juvenile idiopathic arthritis. So the important table is the criteria of classification of juvenile rheumatoid arthritis are important. Okay, so age of onset should be less than 16 years, which is important. Second, arthritis. What is the definition of arthritis? Swelling or effusion or at least presence of two or more following signs. Either swelling or effusion should be there or limitation of range of movement, tenderness and pain in one or more joints. So arthritis definition, because this is juvenile. Now we discussed juvenile means less than 16 years. Less than 16 years rheumatoid arthritis. We are giving definition of arthritis. Next, duration of disease is more than 6 weeks. Okay, basically it should be more than 6 weeks. So three terminology: less than 16 year, less than more than 16 years age, more than 6 week of duration, and arthritis. Okay, so this is definition. Further we dissect it. If onset, we see articular involvement in first 6 months. We see how many joints are involved. If they are five or more joints, it is polyarthritis. If they are four or fewer joints, it is oligoarthritis. And systemic onset disease if it is associated with rash and fever. So this is classical definition of juvenile idiopathic arthritis. Just remember it, very important. Next, juvenile JIA has been classified into various category by ILAR, International League of Association for Rheumatology. Just remember the important points. Systemic JIA. So systemic, obviously arthritis will be there in one or more joint, preceded by fever more than 2 week duration. So this fever duration is important. In Sogia, fever duration is more than 2 week. That is daily quotidian fever. Quotidian fever is important for at least 3 days. Okay, the fever definition, it should be more than 2 week. It should come daily and it should last at least for 3 days. And along with one or more of the following, like first, envascent rash, generalized lymph node enlargement, hepatomegaly or splenomegaly or both, and serositis. So this definition of Sogia is very important. Second, oligoarthritis we discussed also in first 6 months. If joints are 1 to 4 joints are involved, this is oligoarthritis. It has been classified further if joints are persistently 4, persistent oligoarthritis. If they are more than 4 after in first 6 months of disease onset, these are extended oligoarthritis. Polyarthritis, we can divide them RF negative and RF positive. Obviously, polyarthritis means more than 5 joints, and RF positive polyarthritis means RF factor is positive. No, not this. RF factor should be positive at least 3 months apart. Two or more tests during first 6 months of disease. So two-time RF factor should be done up 3 months apart in first 6 months of disease. Then we call it thus polyarthritis RF positive. Psoriatic arthritis, as name is suggesting, arthritis plus psoriasis. It is psoriatic arthritis, yes. If psoriasis is not confirmed, then at least two of following psoriasis features should be there. Dactylitis, nail pitting, and psoriasis in first degree relative. Very important. Enthesitis relate arthritis and plus enthesitis. So enthesitis, what is enthesitis is tenderness and insertion of tendon, ligament, joint, capsule and fascia to bone. This is definition of enthesitis. If enthesitis are not there, at least two of the following: history of sacroiliac joint tenderness, HLA-B27 positive, onset of arthritis in a male more than 6 year old, acute symptomatic anterior-uveitis, and acute history of ankylosing spondylitis. So these definitions are important. Just remember, very important for exam. Next, ACR and ILAR classification of chronic arthritis has been asked multiple times. Just focus on this. We don't call now this is juvenile rheumatoid arthritis. It is juvenile idiopathic arthritis nowadays. Minimal duration age is same, more than 6 weeks and less than 16 years. The joints like oligoarthritis, earlier it was called as polyarticular, now it is oligoarthritis, polyarthritis, systemic features and other features. So this is basic difference for from ACR criteria to ILAR criteria. Okay, so this is summary of all type of juvenile idiopathic arthritis. Okay, systemic arthritis, oligo, polyarticular, RF negative, RF positive, psoriatic, and enthesitis. We will dissect this table in very simplified manner. Okay, first see peak age at onset. Which age is peak age? You are able to see systemic arthritis is 1 to 5 years, means it is around after infancy, and in preschool age systemic arthritis is more common. RF positive is generally around 10 years. Psoriatic arthritis has two peak, 2 to 4 and 9 to 11. Okay, you have to remember those things which I'm highlighting. Okay, male to female or female to male ratio, just see in this condition female are more affected. You are able to see female are more affected, but wait, systemic arthritis, SOGIA, male or female are equally affected. This is NEET SS previous year's question. What is male-female ratio in SOGIA? So this is important. Just remember. And other thing, enthesitis-related arthritis is more common in male, very much more common in male. Other things are more common in female. So this is question. Just remember it. Okay, so percentage of all GI cases, so which is more common basically. So you are clearly able to see oligoarthritis is most common, means oligoarthritis is the most common type of JIA in this table. You can clearly see, just remember only this thing. Arthritis pattern, we saw initially the joints involvement, not much to discuss in this column. Extra articular features are important. Systemic arthritis we discussed, daily fever, rash, pericarditis, pleuritis as definition suggesting. Oligoarthritis, uveitis in 30% cases and polyarthritis, uveitis in 10%, in psoriatic 10%. Okay, so more uveitis is seen in oligoarthritis, very important. RF positive, in which cases rheumatoid nodules seen in only 10% of cases. Very good point, only 10% cases. Anterior uveitis associating reactive arthritis in enthesitis related arthritis. Okay, so laboratory investigation, you will see ANA positivity, RF positivity. So this is generally not that much great. Okay, so in this exhaustive looking table, just remember the highlighted things which we are discussing. Okay, next, these image based questions can be asked directly from Nelson, so just go through once. This is synovial biopsy from 10-year-old child with oligoarticular juvenile idiopathic arthritis. dense infiltration of lymphocyte and plasma cells. Okay, so these images can directly put into exam, so just go through them. This is arthroscopy of shoulder of JIA showing pannus formation. Okay, this is MRI with juvenile idiopathic arthritis, dense white signal in synovium near distal femur. So this is oligoarthritis, oligoarticular juvenile idiopathic arthritis. These images are important. Okay, so how you will examine or these patients, especially ophthalmological examination, you have to refer patient immediately. And if these conditions are there, means oligoarticular, psoriatic, enthesitic, and onset under 11 years, you have to uh, length of screening is like if age of onset is less than 3, 8 years, 9 to 10 is 1 year. Just remember you have to screen approximately for 11 years. So the patient comes to you at 5 years of age, so just add 6 to 6 years, 3 years, okay, approximately 9 to 11 years we have to screen them. Just rough idea, remember this table, this is important, has been asked multiple times. But in polyarticular or ANA positive GIA onset less than 10 years, the length of screening, if patient is less than 6 years of age, length of screening is 5 year. If patient is 6 to 9 years of age, length of screening is 2 years. Okay. Other things are also important, but not exam point of view. Just remember highlighted or we discussed these things. Just remember those only. Okay, again the important image can be asked. So this is polyarticular juvenile idiopathic arthritis with RF negative. Okay, you can see the wrist involvement, you can see the metacarpal involvement and distal and interphalangeal joints involvement. So this is important case of hand thing. Okay, joint distraction in polyarticular arthritis. Someone may ask you, in this condition, loss of articular cartilage, distractive changes in distal and proximal interphalangeal and metacarpophalangeal joints are seen. Okay, this is a rheumatoid nodules in bony prominence. So this typical picture can be asked. These are rheumatoid nodule. What is this? This is CT scan of TM joint, temporomandibular joint, in a child with juvenile idiopathic arthritis. Distraction is showing. Basically, this is bony distraction. Again, for important X-ray of cervical spine. In this condition, cervical spine showing fusion of neural arc between C2 and C3 and severe hip disease in Sogia. So these are important images. Just go through them. Okay, what we're talking about, this high spiking intermittent fever in Sogia. This is called quotidian fever. At least 3 days should be there. Okay, a rash of systemic juvenile idiopathic arthritis. Repeat question. The description is very important. These are salmon colored, macular, non-pruritic rashes. So this description is important and this image is also important. Just go through it once. Okay. Now we'll discuss macrophage activation syndrome. The independent question has been asked twice or thrice. So what are the laboratory features? Just see, you might have observed this case in your clinical practice and award postings also. Laboratory features: cytopenia, abnormal liver function, coagulopathy, decreased ESR, triglyceride will be increased, hyponatremia, hypoalbuminemia, ferritin will be increased, and elevated CD25 and CD163. What are the clinical features? Fever will be continuous, hepatomegaly, splenomegaly will be there, lymphadenopathy will be there, hemorrhage and CNS dysfunction. If you happen to do histopathology, then macrophage, you will see macrophage hemophagocytes in bone marrow and increased CD163 staining on bone marrow. If a patient of Sogia is there, so what will be the criteria for mass? Very important. This question is actually um, most beloved question of examiners. So a febrile patient with no suspected systemic juvenile idiopathic arthritis having will be called mass. as if ferritin is more than 684 nanogram per ml, just remember this is nanogram per ml. Platelet count is less than 181 1.8 lakhs. AST is more than 48, just remember. Triglyceride is more than 156 and fibrinogen is less than 360. This is very important. Just remember all values. These are asked independently multiple times. Okay, now we'll see the MRI of wrist of arthritis showing multiple erosion, and after treatment, this is the image can be asked. So, early radiographic changes in juvenile idiopathic arthritis, you can see soft tissue swelling and periostal newborn formation. These are important. Okay. So, second thing, what we see in this condition, pharmacological treatment of juvenile idiopathic arthritis. So, in this condition, as we able to see, many drugs are used. So I'm just highlighting important concept in this. NSAIDs we can use. Okay, NSAIDs are the first drug we should use. What NSAIDs can we use? Naproxen, ibuprofen, meloxicam. I'm not discussing the doses. If you want to remember, just go through. I'm highlighting important thing out of them. Pseudoporphyria is side effect of naproxen. Repeatedly asked question. Disease modifying antirheumatic drugs, DMRDs, methotrexate, sulfasalazine, and leflunomide. So the important point is uh, which drug need wash out with cholestyramine? Repeat question. This is leflunomide. Okay. Other the doses and other, if you want to remember, you can. Biological agents. So anti-tumor necrosis factor alpha. What are the drugs? Etanercept, infliximab, adalimumab, and golimumab. Okay. So just remember these drugs come under this heading. Okay. Anti-T lymphocyte associated antigen 4 immunoglobulin. So they will ask abatacept drug is in which category? Okay, you have to answer. This is anti-cytotoxic T lymphocyte associated antigen 4 immunoglobulin. Anti-CD20, all we know our beloved drug rituximab. And what is the important side effect is progressive multifocal encephalopathy. So PML is important side effect of rituximab. Interleukin 1 inhibitor, anakinra, canakinumab, and rilonacept. These are important. Okay, this drug has been asked. Interleukin 6 receptor antagonist, tocilizumab, the favorite drug in COVID time. So cytopenia, GI, this can done. And tofacitinib, this is Janus kinase inhibitor. So remember these drug classification, at least an important side effect of some drugs. You will good to go. Okay, this is chronic anterior uveitis demonstrating posterior synecdoche in absence of significant scleral inflammation. This is slit lamp examination shows flare in the fluid of anterior chamber. Just go through these images. These can be asked. Okay, now we'll move to ankylosing spondylitis and other spondyloarthritis. Okay, this is exhaustive looking table. What I want to show you the difference is only. Okay, any of these diseases are rheumatoid factor negative. Just remember this. GI involvement is mostly seen in IBD and reactive arthritis along with mucous membrane. So mucous membrane and GI involvement is seen in inflammatory bowel disease and reactive arthritis. Okay, so other conditions are plus minus. Some like enthesitis will be present in all axial arthritis, peripheral arthritis, anti-B, HLA-B 27 positive, and ANA positivity is seen in juvenile psoriatic arthritis. So these three, ANA is positive in which condition? Juvenile psoriatic arthritis, and skin mucous membrane and GI involvement is seen in inflammatory bowel disease and reactive arthritis. Okay, so inflammatory back pain, once asked, what are the characteristics of inflammatory back pain? Pain will be at night and with morning stiffness. If a patient do exercise, it will get improved insidious onset and good response to non-steroid inflammatory drug. Very important. So this is nail pitting in case of JPSA. So this is very important. Okay, so this is juvenile spondyloarthritis. Again, the one liner question was there, which part is most commonly involved in this? This is insertion of infrapatellar tendon of patella. Caution. Second most part they have asked it also Achilles tendon. So this is first most common and second most common. Okay, so two things they have asked in exam: first most common, second most common. This figure shows the same. Just go through this figure. I'm not discussing it. Okay, you are able to see loss of lumbodorsal spine mobility in a boy with ankylosing spondylitis. No mobility is seen here, and this is well developed sacroiliitis in a boy of ankylosing spondylitis. Just go through these images. Again, we'll discuss SLE. Okay, so this is SLE is important. This is actually ethnic variations can be seen. What I want to focus on sex ratio. Before puberty, it is actually female to male. Female are more involvement, but during reproductive age group, female are 9:1, and post menopausal period near prepubertal ratios. Okay, age it is rare before 5 years. Median age of diagnosis of SL is 11 to 12 years, and 20% of SLE cases diagnosed before 16 years. These every point I'm discussing has been asked in multiple exams in some or other way. So just keep the important points in your mind, or just revise them, because just pay attention to these things. Okay, this is neuropsychiatric symptoms. What are neuropsychiatric symptoms are there? Psychosis, headache, chorea, seizures, mood disorders. Again, I am emphasizing this. We are not discussing SLE in a detail, but exam-oriented view. If you want SLE in detail, we'll discuss in some another video. This video is just focused on important thing for exam, just for fast track revision. So just pay your high level of attention. Don't deviate from anything. So this is actually mucocutaneous manifestation. This is malar rash, vasculitis rash, oral mucus ulceration, and discoid rash. Just go through these image once. You will be good to go. Okay, what are the manifestations of SLE? It may be constitutional, like fatigue, anorexia, weight loss, and musculoskeletal, renal, cardiovascular, neurological, pulmonary, hematology, gastrology, ocular. What the purpose of this image is, every system can get involved. The important thing, so this is 2012 SLIC criteria. In this condition, many things are changed. Like if they are classical discoid rash description has been changed. Non-scarring alopecia in cutaneous manifestation is involved, and urine protein create ratio representing more than 500 milligram protein in 24 hours is included. uh, Hematological hemolytic anemia, leukopenia, thrombocytopenia is involved, and positive anti-double stranded DNA antibodies, anti-Smith antibodies, immunological parameters has been changed. So these are changed criteria. Just go through the highlighted one. Okay, so this is a classical diagnostic framework of SLE, very much important. Okay, you found a patient of according to clinical symptoms, you are suspecting SLE. Do one thing, go for ANA titer. If it is more than 1:80, then we should go for additive criteria. If it is not more than less than 1:80, just rule out SLE. Very important. So first thing we'll do ANA. Second thing, additive criteria. What we will do? We will do at least one clinical criteria and more than 10 point. Very important. What are the points? Do not count criteria if there is more likely explanation than SLE. Occurrence of criteria at least one occasion is sufficient. Criteria need not to occur simultaneously, and which each domain only highest weighted criteria is counted toward total score. So basically, at least one clinical criteria and more than 10 point. Uh, after ANA positivity will be considered as SLE diagnosis. Just see, just be with me. Clinical domains. This is actually clinical domain criteria and this is immunological domain criteria. So in clinical domain criteria, this is first, this is second. Okay, clinical domain criteria, you are able to see these numbers. Okay, so you are able to see these numbers. These numbers are basically weight or points. We'll discuss them. In clinical criteria is constitutional, fever, to hematological, leukopenia, thrombocytopenia, autoimmune hemolysis, neuropsychiatric, mucocutaneous, like non-scarring alopecia, oral ulcer, serosal, musculoskeletal, renal. We discussed also. So just see, the renal biopsy class 3rd or 4th lupus nephritis is 10. So if we found this, we are good to go. We can diagnose this SLE straight away. So like acute cutaneous lupus is 6. So just remember 2 or acute pericarditis is 6. So this should be overall should be 10. What are the immunological criteria? Antiphospholipid antibodies like lupus, anticardiolipin 2, low C3 or low C4, 3, 4. But SLA specific antibody, just remember anti-DS, anti-Smith antibodies, these are 6 points. Okay, so score 10 or more if entry criteria is fulfilled will be diagnosed as SLE. Very important, just go through this part of video once again, you will remember this. Okay, mimickers of SLE. There are many mimickers. Just go through this table. Infectious, hematological, and solid tumors can do. Medications associated with drug-induced lupus. These medications, actually these has been asked twice and thrice. Just go through this table once again. I'm not discussing all drugs. Just go through once, and you will learn about this. This is very important. Okay, you have to mug it up. No way to explain this table. Okay, O2 antibodies, this is important table. Anti-DS DNA, we discussed, this is anti-double stranded DNA. This correlate with disease activity, especially nephritis. Okay, anti-Smith, S for specific. So this is mnemonic, kind of mnemonic. Anti-Smith antibodies specific. Ribonucleoprotein anti-RNP antibody R for Raynaud disease, so R2R. Okay, you can remember this. Anti-Rho, anti-La, all we remember. SSA and SSB for what? Neonatal lupus. This neonatal lupus, but apart from neonatal lupus, it is also associated with Zika syndrome, Sjogren syndrome, and isolated discoid lupus. Very much important. So this is Zika and Sjogren has been asked which antibodies are involved. Antiphospholipid antibodies are involved which suggestive of venous or arterial thrombotic events. Antihistone antibodies, drug-induced lupus, the hallmark of drug-induced lupus. Just go through this table once again, very high yield table. Okay, so like lupus emergencies, many emergencies can occur. Just go through this table: fever, thrombosis, chest pain, dyspnea, headache, altered mental status, rash, icterus, petechiae, seizures. Okay, so and mortality according to the system involved. So you are familiar what are the lupus emergency. Just at least remember the headings, heading part of them. Okay, neonatal lupus, very important. You did examination, you found anti-Rho or anti-La pregnancy. How you will go through? You will do fetal monitoring with echocardiography from 17 to 26 week. If fetal echo is normal, then what you have to do? If baby is born, we have to do ECG and echo at first month and 1 year. First month and 1 year. If ECG fetal echo is normal, very much important, has been asked twice. Okay, if it is not normal, your PR interval is more than 140, then you have to repeat fetal echo first thing. But if your PR interval is more than 150, what you will do? Will start dexamethasone 4 to 8 mg daily for 1 week. Okay, but important. If you found AV block or signs of CHF, you have to do you have to give dexamethasone 4 to 8 milligram daily plus IVIG. So what is the indication of IVIG in lupus, AV block or CHF and myocarditis? But again, just see, third degree block and severe hydrops fetalis. In this condition, if severe hydrops fetalis is there, dexamethasone, obviously you give IVIG, you will give apheresis can be done, and if it is uncontrollable, termination is required. So this is beautiful explanation of neonatal lupus management. You are able to see the typical rashes, open malar distribution, appearing as annular plaques with erythema and scarring. So this is neonatal lupus syndrome. This image is also very much favorite for examiners. Okay, so again, next topic. Before going to next topic, just quick reminder. This is a revision series for NEET SS Pediatric. It is not complete explanation of topic. For complete explanation of topic, go through that NEET SS Pediatric PYT series. We'll continue this, but as of now, for exam point of view, just go through these important points again. Juvenile dermatomyositis. What are the diagnostic criteria? These are classical rashes, heliotrope rash with eyelid, golden papules, plus three of the following, means a rash should be there, plus three of the following. What are the three? Weakness. Weakness should be symmetrical or proximal. Very important. Proximal weakness is seen in juvenile dermatomyositis. Muscle enzymes should be increased more than one. EM electromyographic changes like short, small polyphagic motor units and muscle biopsy should show necrosis and inflammation. So this is facial rashes of juvenile dermatomyositis over bridge of nose and malar areas, or this is a rash of juvenile dermatomyositis on metacarpal and proximal interpharyngeal joints. Okay, so these images can be asked because these are beautifully explained in Nelson. What is this? This is perivascular and perifascicular inflammatory changes. Second, MRI suggestive of myositis. And third, this is important, capillary are most abnormal when viewed at nail fold. This is capillary abnormalities, and this image has been repeated PYQ. Okay, in this image you are able to see dystrophic calcinosis. So this is dystrophic calcinosis is important, and cutaneous ulceration you are able to see along with lipoatrophy of forearm. So this is lipoatrophy. So in this image, this is important, and this is important. So just go through these important images once. Okay, this is treatment plan. Don't go with doses. See, moderate JDM, skin predominant JDM, and skin resistant JDM. What are the drugs? You just remember them. Methotrexate, prednisolone, methylpred, IVIG combination is used. But in this skin predominant, you able to see hydroxychloroquine is used. So this is added thing in this, and MMF and cyclosporine are used in skin resistant JDM. Just remember these two, hydroxychloroquine and MMF and cyclosporine. Okay, you need not to remember all the doses, just right before exam. Okay, so this is Behcet disease, all we know. So this image is important. Deep aphthous ulcer. So recurrent oral aphthous ulcers, at least 3 attacks per year. This is previous is asked question 3 or 5. Yes, this is 3. Genital ulceration, skin involvement, ocular involvement, neurological signs, vascular signs. Okay, it's all good. So Sjogren syndrome. So this is important classification. Juvenile Sjogren syndrome is associated with parotitis, parotid enlargement, recurrent conjunctivitis, and objective tests are important like ocular dryness, abnormal cyalography, elevated serum amylase, leukopenia, and elevated ESR. Serology is anti-SSA, anti-SSB, and histopathology lymphocyte infiltration. I'm going very fast because time is important, time is key in this fast revision series. So please keep pace with me. And if you want to revise any stuff again, just go through, rewind the video and revise. Okay, we'll cover important things. Kawasaki disease again. the favorite for examiners. Just see this part, okay, this part. So the fever should be at least 5 days, and at least four principal criteria. What are the four? Change in extremities like palm, soles, edema, polymorphous exanthemus, bilateral bulbar conjunctival injection without exudates, erythema, cracking of lips, cervical lymphadenopathy more than 1.5 centimeter diameter, usually unilateral. So the diagnostic criteria has been asked multiple times. Ignore the other part of table. Okay, so this is classical pictures which has multiple times. This image is very favorite for examiner. This is strawberry tongue. Okay, in Kawasaki disease, bulbar conjunctivitis. So this is actually non-purulent. This is edema of hand, and this is desquamation, generally seen in second week or convalescent phase. These go through these images. These are important. Okay, if incomplete Kawasaki disease is presenting, so this is becoming favorite questions for examiner now. How you will go through? Okay, so if how it is, we can call it incomplete Kawasaki. Fever is more than 5 days, but you are not meeting the four criterias, but you are meeting two or three criteria, or fever is more than 7 days and no explanation is found. What you have to do, just do CRP and ESR. If CRP is less than 3 and ESR is less than 40, think of another entity. If it is more than 3 CRP and ESR is more than 40, you have to do lab test and echo. If echo is positive, your diagnosis is Kawasaki disease. If echo is negative, then C laboratory finding 3 or more should be there: anemia, anemia, thrombocytosis after 7 days, albumin less than 3, elevated AST, TLC more than 15,000, and urine more than 10 WBC per high power field. So this is important. Just see this and revise again. Diagnostic criteria of incomplete Kawasaki disease. Differential diagnoses for Kawasaki are many. Just go through them once: viral diseases, bacterial infection, rheumatological disease, and others. Okay, so multi-system inflammatory syndrome. So this syndrome, have you heard in COVID very much? MERS syndrome. We have to actually differentiate it from Kawasaki. So just important table. So MIC generally the age is 8 to 12, but Kawasaki's age of preschool children less than 5 years. You know, in Kawasaki fever is more than 5 days, but MISCC in multi-system inflammatory syndrome fever is more than 24 hours. GI symptoms like abdominal pain are more common in this multi-system inflammatory syndrome, and heart myocardial dysfunction are generally more common in MIC. Coronary artery dilatation and aneurysm in 25 to 50% patients. Hypotension is seen, renal involvement is seen, pro-inflammatory state, lymphopenia, thrombocytopenia, elevated ferritin. This is important. If we do ferritin is more, we will think of multi-systemic inflammatory syndrome. So just go through these highlighted points like ferritin, like hypotension, renal involvement, GI symptom, fever more than 24 hours, and mean age of 8 to 12 years. We are able to differentiate it. Okay, so how you will treat the Kawasaki acute stage? Just remember important table of this discussion. If acute stage, you have to give IVIG 2 gram per kg over 10 to 12 hours plus aspirin 30 to 50 milligram per kg per day divided every 6 hourly orally until patient is afebrile for at least 48 hours. So first give IVIG single dose plus aspirin in high dose like 30 to 50 milligram per kg per day at least 48 hours patient afebrile. This is standard treatment followed everywhere. High risk. If patient is high risk, how you will identify high risk? Just see if age is less than 6 months or baseline LAD or RAC score is more than 2.5. So if age is less than 6 months or Z score is more than 2.5, this is high risk case. What you have to give? IVIG we have to give plus methylprednisolone, the hero of the this discussion. MPS, yes, steroid. You have to give 2 milligram per kg per day divided 12 hourly until febrile, then prednisolone until CRP is normalized. So basically, what you have to give MPS. MPS should be tapered with prednisolone until CRP normalized, then taper over 2 to 3 weeks. Very important. What is the management of convalescent stage? We have to give aspirin, but dose is different, 3 to 5 milligram per kg orally until 6 after illness onset or normal coronary finding throughout the course. So just go through this table again and revise again. This is very important. Anticoagulation therapy. What we have to do long-term therapy. If small aneurysm is there, aspirin we can give in 3 to 5 milligram per kg per day. If medium aneurysm is there, two anticoagulant aspirin and clopidogrel. You have to give if giant aneurysm. This is my question asked. In giant aneurysm, you have to give aspirin, anticoagulation warfarin, low molecular weight heparin, and direct oral anticoagulants. If acute coronary thrombosis is there, prompt fibrinolytic therapy with the tissue plaquenil activator and other thrombolytic agents. So this is important. Just go through this once again, and it is actually important to consider this. Again, the important favorite question of examiners: what is the treatment of IVIG resistant Kawasaki disease? So first we have to give IVIG second infusion. The first step, they ask first step, which is the first step. So this is the first step. Second, IVIG plus methylprednisolone and prednisolone. So this is the second, IVIG plus glucocorticoids. Infliximab, this is monoclonal antibody against tissue necrosis factor alpha. So infliximab is also asked. What other drug we can give? Anakinra, cyclosporin, cyclophosphamide and plasma exchange. So these drugs are important. Just revise them once again. Okay. So vasculitis syndrome, again just one or two topics. Vasculitis syndrome, polyarteritis nodosa and Kawasaki disease we just discussed. Leukocytoclastic vasculitis, HSP, hypersensitivity granulomatous vasculitis is granulomatosis with polyangiitis, also called as vaginal granulomatosis, and EPGA drug stress syndrome, Takayasu arteritis, and temporal arteritis. Just go through the classification part of these arteritis. These are discussion of these detail of discussion is out of scope this discussion, because we are just revising high quality stuff for NEET SS pediatric upcoming exam. Last but not least, this HSP. Okay, the criteria are many times asked. Palpable purpura should be there in the absence of coagulopathy or thrombocytopenia. At least one or more of the following criteria should be present, like abdominal pain, arthritis, biopsy of affected tissue demonstrating predominant IV deposition, renal involvement is more than 0.3 gram per 24 hours, hematurian red cell cast. Just mug up these criteria, very important. This image has been asked multiple times. These are palpable purpura. This is skin biopsy showing direct immunofluorescence IgA of dermal capillaries. So this is IgA deposition, and this is HSP rashes classically. So this image has been asked multiple times. Okay, so yeah, we have completed all our discussion of this beautiful chapter of rheumatology. Hope you will find it useful. Just go through once again, revise it, and mostly you'll get around 60 to 70% question correct by this discussion only. Okay, so we will be continuing this series of revision series, the NEET SS pediatric exam, system wise. Okay, so just be with me. Do share, like, subscribe, and I will do important announcement in the exam also. So keep keep studying, and just revise the stuff. Okay. So, so we'll meet in another video. Till then, bye bye.